Hello everyone. Today we will be discussing management of tubercular pleural effusion and tubercular lymphadenitis. While lymph nodes are the most common extrapulmonary site, 33% involved, pleural involvement is the second most common. This lecture is based on the training module on extrapulmonary tuberculosis, released in May 2023 by Ministry of Health and Family Welfare, India. Today's lecture is divided in two broad topics: management of tubercular pleural effusion and management of tubercular lymphadenitis. As we all know, management of any disease comprises of its diagnosis and its treatment. First, we will be discussing management of tubercular pleural effusion. To diagnose pleural effusion, we need to do chest X-ray of the patient. Rising homogeneous opacities and obliteration of costophrenic angle are two most important chest X-ray findings in a case of pleural effusion. Pleural effusion is diagnosed by ultrasound of chest tube, following which thoracentesis is done. 20 to 40 milliliters of pleural aspirate is required for the requisite tests to diagnose tubercular pleurisy. A repeat chest X-ray is often done after the procedure to assess for iatrogenic pneumothorax. If diagnosis is still not clear, then in such cases we perform pleural biopsy. This is a chest X-ray depicting right-sided pleural effusion. The findings are right CP angle obliteration, rising homogeneous opacity and mediastinal shift to the contralateral side. Chest radiograph is done in all patients suspected of pleural effusion. Chest X-ray par view detects 200 milliliters of pleural fluid. Lateral decubitus is the best position to detect pleural fluid via chest X-ray. Ultrasound of chest is another important imaging modality for detecting pleural fluid as low as 50 milliliters. Tubercular pleural fluid is generally exudative, lymphocytic in nature with high glucose and adenosine deaminase levels. ADA levels in pleural fluid is a semi-specific biochemical marker for diagnosis with a cut-off level of 40 international units per liter. It has a sensitivity of 92% and a specificity of 90%. ADA more than 70 international units per liter is highly likely to be tubercular pleural effusion. But it should be noted that high ADA is also found in empyema and rheumatoid pleurisy. ADA levels between 40 to 70 international units per liter is an indeterminate level. Hence, symptoms and risk factors related to tuberculosis play an important role in diagnosis of such patients. Pleural fluid ADA less than 40 international units per liter indicates an alternate diagnosis. To summarize the diagnosis, tubercular pleural effusion should be exudative according to Light's criteria, lymphocytic with a high ADA. Light's criteria will be discussed in detail in upcoming videos. Pleural biopsy is required if diagnosis is unknown even after diagnostic thoracentesis. Pleural biopsy may be done by three possible methods: percutaneous pleural biopsy, which includes closed pleural biopsy and CT-guided cutting needle biopsy. The closed pleural biopsy may further be done blind or as an ultrasound-guided procedure. Thoracoscopic pleural biopsy is useful in cases with a negative percutaneous biopsy, suspicion for patchy disease, or for a more detailed workup for malignancy. Open biopsy via thoracotomy is a surgical procedure that has largely been supplanted by the previously mentioned methods. Chest X-ray, HIV and RBS testing should be done in all cases of tubercular pleural effusion, while CT chest and abdomen is done if malignancy or disseminated tuberculosis is suspected. Ultrasonography of chest is done in selected cases, especially loculated pleural effusion, adhesions, pleural thickening. Fluid can be quantified and small volumes may be aspirated under ultrasound guidance. Pleural thickening can be differentiated from pleural fluid by both ultrasound chest and CECT thorax. Therapeutic thoracentesis is only required in case of respiratory distress. Tube thoracostomy is done in cases of massive pleural effusion, empyema and hydropneumothorax. Sputum examination is done to rule out concurrent pulmonary tuberculosis. Pleural biopsy, as discussed earlier, is done in case of unclear diagnosis even after pleural fluid examination. Treatment of tubercular pleural effusion consists of anti-tubercular treatment or ATT, pleural fluids drainage, proper nutrition. If the effusion is causing respiratory distress, shortness of breath, increase in respiratory rate, pleural fluids drainage can be done. Corticosteroids are not recommended for the treatment of pleural tuberculosis. Now, coming towards the second section of our lecture. Tubercular lymphadenopathy, the most common form of extrapulmonary tuberculosis. Cervical lymph nodes are the most commonly affected by this disease. All patients should undergo a detailed clinical examination and routine evaluation. In patients with deep lymphadenopathy, all peripheral lymph nodes must be assessed for the presence of lymphadenopathy and preferred for sampling. Chest radiograph is to be performed in all patients. Size of lymph node is significant if more than 2 cm diameter in the inguinal region and more than 1 in other regions. Consistency of lymph node may be soft, hard, firm or rubbery. Fixed lymph nodes are seen in malignancy and inflammation. Matted lymph nodes are described as a group of nodes that are conglomerated. They can be either due to benign diseases such as mycobacterial infection and sarcoidosis, or malignant disorders such as lymphoma and metastatic carcinoma. Jones and Campbell classification of peripheral tubercular lymphadenitis divides tubercular lymph nodes into 5 stages. Reactive lymphadenitis, periadenitis, cold abscess, collar stud abscess, and sinus tract formation. This is a flow chart on how to approach a patient of lymph node TB. All aspirated samples are sent for cytopathology, nucleic acid amplification test, ZN staining and TB culture. Lymph node TB can be either bacteriologically confirmed or clinically diagnosed. Bacteriologically confirmed LNTB is positive on AFB staining, NART, or culture. Clinically diagnosed have clinical and histopathological features in favor of the diagnosis. Histopathological features of tuberculosis include presence of epithelioid cells, granulomas, and necrosis in the lymph nodes. LNTB primarily requires medical management. Adjunct surgical excision is generally associated with worse outcomes. LNTB patients can be managed at the primary care level. 6 months ATT standard first-line regimen is recommended for peripheral lymph node TB. Initial 2 months as intensive phase, continuation phase from 3rd month onward, for 4 months. I really hope that this lecture was of some value to your knowledge. Stay tuned and do subscribe this channel for more updates.